with you.
Okay. All right, thank you very much, and good morning, good afternoon, good day to you all. I'm very excited to be part of a conversation on COVID-19 and its implications for the aging population. Obviously, one cannot do justice in just 30 minutes, but yeah, that was generous though. We know we are normally given 10-15 minutes in this talk. So I'm very excited, and I must heartily thank Professor Jaco Hoffman for being a constant and consistent friend that has always made sure that I do not forget, even when I took management positions, the fact that my first love, basically. And when he saw that I'm now available for this kind of work, more directly, he has approached me on several other initiatives. So I'm very, very much happy to be part of the Hillary Seminar Series, and I want to thank the Oxford Institute of Population Aging and the University of Oxford broadly for having afforded me the opportunity to speak, and I hope that this is the beginning of greater collaborations. I must say my university leadership is looking forward to more exchange and engagements with the University of Oxford, and of course working together with my home friend here, Professor Jaco Hoffman. So yes, I'll be talking about COVID-19 in South Africa with respect to the importance of understanding epidemiologic heterogeneity in order for the responses that we give to become equitable. I believe very strongly, together with other colleagues, that we started working on epidemiologic heterogeneity of COVID-19 when it started, that it is, one cannot use a blanket approach. Otherwise, you'll end up with ineffective interventions. And we also cannot assume homogeneity. Again, it will make our prediction models faulty or inaccurate. So it is important to explore epidemiologic heterogeneities in terms of infection, severity, and mortality, so as to understand the differential impacts and ultimately to guide governments and various stakeholders in ensuring that our control measures and resource allocation is accordingly structured. So what I did here, because I really wanted to focus my talk on some specifics without necessarily being able to exhaust everything, I reviewed publicly available data, the NICD surveillance reports, the DATCOV, which is a hospital-based surveillance mechanism that was established by the NICD in order to keep data on hospitalized patients. As you know, it's very difficult to monitor trends and patterns, even of mortality, if without a captive audience. So we know the embedded weaknesses of doing so, because obviously generalizability is a problem with respect to hospital-based surveillance system. Of course, we've got the national surveillance system, which is the one monitoring cases and deaths and so on, which is much more generalized. I'll start with what we obviously know. We know the epidemic is growing, and there's marked heterogeneities in number of cases and in number of deaths. We know that the northern hemisphere compared to the Southern Hemisphere, has much more cases and deaths than, it is the case with the Southern Hemisphere. There are still questions to be answered and various hypotheses with respect to acquaintance with dealing with epidemics like Ebola and so on, immunity profiles and so on. But that's not a subject for today. I think the point I want to make is the fact that we are all confronted. South Africa is the most impacted country in the continent, and in the world, we know that the UK and the US and so on are also greatly impacted, and we are all, this is a topical issue on the public health agenda and in other spheres, because this is not just a public health issue. I've taken the cumulative, the graph from the NICD update report for March 2021 and December, which clearly shows you that women have higher COVID-19 infection rate than men, and that this has been consistent. And there are various, factors that are attributed to this, including the fact that most women are frontline workers. We know in South Africa we've got fewer women in management positions, so most of them, even in the public health sector, there's no exception, so they may be more vulnerable. And also the health-seeking behaviors of women, it could also be that men don't test as much, and thus we see more women than males, yes, who generally have reluctance in seeking health services. And as you can see, across age groups, like you see that the 25, in fact, the graph goes up as the age grow, and it then starts caving in. I'll comment on that. Even in the other graph, you see a similar pattern, but I think it's critical, to say in all cases, even if we're seeing sort of a normal curve, COVID-19 mortalities and infections and so on increase by age, which is quite critical for our talk today. Yeah, now looking at hospital admissions, and this is like latest NICD report as at 27th February. Oh, I'm sorry, I see I wrote 2012. It was meant to be 2021. So across 642 facilities, there were 112,392, which was 51.6%, and 105,499 patients admitted to public and private health facilities. And this relates to the Dutch curve, the admissions data that I mentioned that I have looked into. And of these admissions, 3.3% were in hospital at the time of the report. 74.7% had been discharged alive or transferred. Meanwhile, 21.6% had died. And the case fatality rate, among those with an in-hospital outcome, that is those who died or discharged, was 23.1%. When looking at the percentage of deceased COVID-19 patients with comorbidities, looking at the May data in a selected province, you would see that quite the mortalities or the deceased COVID-19 patients had comorbidities, with hypertension and diabetes being the highest. And this is gonna really take a lot of my conversation with you this afternoon, because the elderly population has got much more non-communicable diseases, than any other age group, as their immunity levels become weakened and the physiological processes become compromised, and thus they become more vulnerable to acquiring any infection, or viral or bacterial infections than any other age group. So I just took one of the articles I came across, to say, looking at, again, the age issue, those who were aged more than 70 years and above had, 13.7% higher mortality compared to those who were under the age group of 70 plus. I mean, the writing is on the wall. This has serious implications. And I looked also at the percentage of diseased COVID-19 patients having different comorbidities by age group at death. And here you'll see that, firstly, NCDs increase with increasing age, and the percentage of diseased patients was highest among those with hypertension. I've tried to for my notes, the yellow bars, and hypertension was highest in the 60 to 69, 50 to 59, and 70 plus age categories respectively. And diabetes also highest in those higher age groups, as reflected. Similarly, obesity highest in higher age groups as well, although we see different here, the 2039 age group in terms of obesity being slightly higher, but obviously hypertension and diabetes still being high. And HIV, as expected, being higher in lower age groups, 40-49, which is an adult population too, but comparatively speaking with the rest of the other age groups, it's lower. However, that's another very critical co-infection with COVID-19. And I've indicated asthma, cancer, cardiac diseases, they follow the same pattern and they just vary in prevalence. So again, we can clearly see that these comorbidities are quite a critical factor in terms of COVID-19 impacts. And this becomes, the issue of differential impacts becomes quite critical, given the fact that these comorbidities are quite prevalent in older age groups. Here we see COVID-19 outcomes in hospitalized diabetes patients, and just to illustrate the point here, among 14,242 COVID-19 cases who had diabetes, 440, there were those that recovered, 440,690 were still recovering, and 190 died. So basically we had 14,242 cases, and among these 1,320 were diabetics, and the distribution is as you see it. And among those who died with available measurement of blood glucose control, 68% had poorly uncontrolled diabetes. Again, we know the interruption of COVID-19 to the public health system, which has impacted on accessibility of treatment for chronic diseases, and this may also have been a factor that has increased the mortality and morbidity rates and hospitalization, which overwhelms the public health system, which is already overstretched. And when you look at the public sector only, because here we've got better certainty of previous diagnosis of diabetes, among 8,702 COVID-19 cases in adults, 11% had previously been diagnosed, and among the 696 of these diabetic COVID-19 cases who have an available blood glucose control measurement in the last 2 years, 64% had poorly controlled diabetes at last measurement. Quite serious, and the pie chart definitely demonstrate the point in terms of poorly controlled diabetes and the glycosylated hemoglobin, or HbA1c, which was measured and it found to be poorly controlled. So in multivariate analysis, older age, being male, being African, colored, or Indian, or shall I say non-white, and admission in public sector was strongly associated with COVID-19 mortality. And in these 4 blocks, I just tried to demonstrate or elaborate on attributable factors to that. And I think I've been talking a lot about older age and why is it more vulnerable, and talking on the admission in the public sector, being admitted in a public sector. Again, we know the South African constraints in terms of the public health sector, which does not have sufficient capacity in various ways, to deal with pandemics. And it has always been overstretched, and also some of the social determinants or health inequities and inequalities that have been prevalent for quite some time have surfaced, which contribute to the complexities of COVID-19, where 50% of health resources are enjoyed by 16% of the population, that is those who have medical insurance, and with 73% of Black Africans not having a medical aid, thus making them more vulnerable, and more than 80% of public health care, versus less than 20% being available. Like in fact, more than 80% of the South African population use the public health care system. And demographically, it would be those with low socioeconomic background, which exacerbates the problem. Block 3 goes into much nitty-gritty detail in terms of income inequalities and poverty levels and unemployment rates, and which make Black Africans more disproportionately affected by COVID-19. We do not have, there's still a lot to be done. This is not conclusive. This was among the hospital population, and the multivariate analysis was done with that grouping. So one would still want to do a lot more, to see associations in different contexts, and to also see these demographic factors, how they play out in the bigger population. Being male was also strongly associated with COVID-19 mortality, and I think the other side of the coin is exactly what I mentioned about females. Low health-seeking behaviors might lead to males seeking help or going to the health facilities at a much later stage when they are already severely sick, and they may have had an underlying health condition which may not have been detected because they would not have gone for to the health facility. So a lot more still needs to be done also to establish the reasons for this. Hypertension, obesity, diabetes, I think here I was trying to explain, I'll just skip that one, the low the suppression of immune levels, which make people susceptible to NCDs, or elderly people susceptible to NCDs. I want to touch on the issue of multimorbidity. The whole notion of multimorbidity is a very common phenomenon, and I know you know as well as I do that there are shared determinants of non-communicable diseases. So when you have one, you're likely to have the other. And as you can see, 25% there, 23% of individuals with more than one comorbidity or multiple comorbidities have been more vulnerable to COVID-19 mortality. And the whole issue of multimorbidity adds, to the complexity, because there's variable severity, variable functional processes, physiological processes, and there are complexities in terms of pinning each one down, like to say, to establish what actually transpires, because there are multiple interaction effects, there are multiple confounding effects. So essentially, I took this to demonstrate the point about the importance of or the complexity around needing to have differentiated models or differentiated strategies towards the aging population when it comes to COVID-19, because a homogeneous approach in the context of a country, for example, like South Africa, which is a high disease burden country, we can have interventions that are amiss. So it is quite important to appreciate the fact that we have a high disease burden country with multiple comorbidities, and the fact that the aging population is mostly affected, and we know aging is one and has been one of neglected areas from time immemorial. And I hope that as scientists who are interested in the welfare of where we are all going, that is aging, we will hold the bull by its horn and really be the mouthpiece for this often neglected population that can suffer the most. I want to allude to the words of Dr. Jonathan Quick at the Kaiser Family Foundation, talking about going beyond the Millennium Development Goals. I thought this statement still holds today, that great challenges still face us on building up what we know, scaling up, improving approaches and tackling multimorbidities. Policy actions and intersectoral local actions are critical, even at this COVID-19 times. And I giving a keynote address, and I thought this is appropriate to share. I said, I'm blessed to have both of my parents who are both around their 70s, but their health has deteriorated due to multiple morbidities. They are part of the statistic, and those statistics are not numbers. They are human lives that really need to be cared for. And the plight of many South Africans with respect to multimorbidities and other underlying conditions, HIV and so on, we being in the epicenter of the epidemic, it's a matter that I believe from a life cost perspective, it's yes, there are health risk behaviors that need to be improved, but there are social determinants of health that could have influenced the kind of chronic diseases that today many of the South Africans suffer. I'm saying this also from personal experience with my parents, that they eat healthily, they try to do walks, they are very strict about, lifestyle issues. But still, with even that, probably they would have died if they had not done that. But it is beyond that. There are poverty levels, unemployment levels, and whatnot that have contributed to some of these conditions. Again, coming to or honing in on the issue of differential impacts, for the aging population, NCDs account for more than 50% of death, and for communicable diseases is 40%, and this had been actually going down in South Africa, because in South Africa NCDs were the leading cause of death over the last 3-4 years, according to Stats SA. Comorbid conditions have been consistently cited as drivers of COVID-19. NCDs have been associated with adverse outcomes not only in COVID-19 but in previous pandemics. And there's a paper we wrote that we published in the South African Medical Journal last year, talking to learning from past pandemics. Because there's a lot, society didn't just exist yesterday. We've been there. There are lessons we can learn. Although with COVID-19, we have seen that some of the envisaged predictions we have made, for example, in our paper, about the fact that when winter starts, we will see more cases, which we did see, but we were again shocked when the second wave happened in the middle of summer, and we saw the peak was even much higher. So a lot of it's an exciting time for us as scientists, really, to find out, but obviously a challenging time in various respects that you all know. So the aging population deserve to be prioritized for reasons that I have explained with respect to their ability, to handle the impacts or to handle any new infections, due to physiological weakness. I believe that, South Africa, for example, is one of the countries that has got the highest proportion of elderly population. And it just puts more weight on us as a country, and it's an opportunity for us as scientists, working together with great institutions like University of Oxford, to deal with the complexities that COVID-19 has brought. Because if you look at us being the epicenter of HIV, us having the highest growing elderly population, and us being a country in the continent, that has the highest proportion in terms of number of cases and death, it presents a great opportunity to explore ways of mitigating the impacts of COVID-19. I've alluded to differentiated care models, targeted public health interventions, generating evidence that would challenge low resources and inadequate capacities that is allocated or to the problem of NCDs and the aging population. Our surveillance system is for NCDs is not as robust. Yes, there are surveys, including the Aging and Health Survey, which has really been quite instrumental in generating evidence on the aging population, on indicators that were never measured in our country before. And this is a longitudinal study. There's lots of data that we can analyze further, to see how we strengthen our fight, against the often forgotten grouping. So there's a lot to still look into the biological, behavioral, and environmental determinants. I made a lot of hypotheses in my presentation. We're learning as we go when it comes to COVID-19, and utilization of historical data, like triangulation of various data sources, I think will take us a long way in terms of determining, where to go from here amidst the competing health risks, especially in South Africa, that we are dealing with. I wish to acknowledge the colleagues from local and abroad that we continue to work with on heterogeneity of COVID-19, and trying to find evidence that can inform policymakers in a very focused manner. Thank you very much. I hope I've, at least in terms of heterogeneity, you understand where one is coming from with this concept, because I think it's quite key for diverse countries. A blanket approach might really not do justice. Thank you very much.
Thank you, Refilwe. So this was comprehensive and fascinating. So ladies and gentlemen, you've heard the epidemiologist, but with a social heart. Because Refilwe was first a social worker, and then she studied epidemiology. So this is now the opportunity to raise some questions, and some of it may be transferable to other countries or other contexts. So we now have the opportunity for comments, questions, and so forth. So if you raise your hand or give me an indication,